We will move on to our second topic for discussion today, overcoming challenges to treatment adherence. And I am delighted to formally introduce Associate Professor David Yeung from Adelaide in Australia and Dr. Ana Inés Prado from Montevideo in Uruguay as the experts for this topic. As you can see, they are experts in all topics. David is preceded by his reputation, widely known and highly respected around the globe as a clinical and laboratory hematologist. He's back as an international expert in this forum by popular demand. Welcome again, David. We're very lucky to have you here again. And our final expert for today, Ana Inés Prado, has been the leader of the CML clinic at the Maciel Hospital since 2008. She's a co-founder of the Uruguayan Group for Chronic MPNs. She's active in the Latin American CML group and part of the steering committee for the ICMLF's Latin American Regional Discussion Group. Ana Inés will present in Spanish. It's a real pleasure to share the floor with you again. Bienvenido, Ana Inés. And I will, oops.
Thank you, Arlene, for your kind introductory words, and thank you all for joining me, us. And I'd like to thank the Foundation for this opportunity to make this presentation, and Dr. David Yeung for also being here with us. I'd like to talk about overcoming the challenges that we all face when it comes to treatment adherence for patients. As we all know, CML calls for long-term treatment, and long-term adherence is critical to achieve treatment goals. As we've seen from the publications that have been presented, that 30% of patients are non-adherent, as per Ibrahim and Efficace. And based on Marine's paper of 2010, we saw that even small reductions in adherence, even if it's just less than 95%, can have a major impact on long-term response and achieving therapeutic goals, and also stopping treatment. So this is why adherence really matters so much. The more exposure the patient has to the drug, the higher the effectiveness achieved. This will influence BCR ABL inhibition in order to attain deep molecular response that is sustained. And in that case, if the patient is eligible, they can go towards discontinuation and TFR, and this has an impact on a patient's survival, even if they have to stay on treatment. So we have a couple of clinical cases, and these are young patients where adherence is more of a problem. This is an 18-year-old female patient. At the time of diagnosis, she was 18. She was a midwifery student with chronic phase CML, low risk. She was started on imatinib, which is the first line of treatment available in Uruguay and authorized in Uruguay, but she had therapeutic failure due to lack of adherence. Then she was switched to dasatinib, and once again, there was failure due to lack of adherence. As we were able to get to know the patient better over time as we treated her, and based on her personality, we realized she was very impulsive. She had 2 unwanted pregnancies with 2 terminations, and we thought that it would be necessary to refer her to psychiatry. And the psychiatry team said that this patient had a personality disorder type B with histrionic and narcissistic traits and also borderline personality disorder. And this was, of course, what was hurting her adherence, treatment adherence. We talked to her and she explained that for her, it was very hard to keep up her treatment, and adrenaline was what drove her in life, and just running the risk of failing with her treatment was something that she felt was very exciting. So she was put on psychiatric treatment. This is another patient, a 22-year-old male, an employee, and he was diagnosed with chronic phase CML, low risk. He was started on imatinib, and he had good response. He started reaching therapeutic goals. However, once he did reach complete molecular response, he started failing with adherence. He explained that based on his lifestyle, that he was young, it was hard for him to keep taking the treatment. So at first follow-up, his complete molecular response remained, and that's when his adherence and compliance became even problems became even worse. That's where his response started to decline. So we checked for any mutations, resistance, and he tested positive for T315. And when we request the test, when that's done and we get the results, sometimes it takes up to 2 months for us to get the results. And over that time, the patient's response declined because he was T315I positive. So we put him on ponatinib, but ponatinib is not covered by the healthcare system in Uruguay. It's not on the formulary, so you need to go to the court system to gain access to the medication. So once that was done, he's recovered his response and he's still in deep molecular response. When we talked to this patient, he said that he couldn't even realize how well he was doing with the treatment, and treatment failure due to lack of compliance of adherence shocked him more than when he was actually diagnosed with the disease, which was 3 years before, and that really made him change his attitude. This means that we need to have an approach that includes biopsychosocial elements, pharmacology, lab, and the patient's immune response, because all of this will help patients improve their quality of life and life expectancy. So we need to combine all of these patient dependent factors plus social factors and factors that come have to do with the healthcare system and the patient-doctor relationship, so that all of this can be brought together to help with treatment, with compliance, and for the patient to attain their therapeutic goals. So going a bit deeper into detail, patient-related factors are, well, first of all, how much the patient knows about health in general and about their disease in particular. As with the first case, um, people who know about biology, for example, are not necessarily compliant patients. Also, the perception of risk and disease severity on the part of the patient is very important. It's in the literature that young patients are less compliant than older patients, and older patients, of course, we have to bear in mind other comorbidities and the presence of polypharmacy. Another thing that we also saw is that psychological traits and coping strategies. that patients have, and I'm not necessarily talking of psychiatric disorders, as per Richter. Personality types do have an impact. So an A-type personality, these are people who are more anxious, more demanding, and find it harder to comply. And D-type personality patients are more pessimistic, they're more negative, they have a more negative view of life. Well, that has an impact on compliance as well. And having the patient be involved in decision making is very important, and especially when it comes to younger patients, but that's true of all age groups. When a person is diagnosed with a disease that interferes with their plans, their life plans, so how they bring this on board and how they factor that into their lives, that's going to have an impact on compliance. And social and cultural traditions can have an impact on compliance.
So when we talk about the factors that depend on the treatment directly, we see the complexity of pathology, the also the use of other drugs, or also limitations on the diet can also have an impact. Also, we have common adverse effects that many times for doctors have less importance, but they do affect adherence because they do impact the day-to-day of the patient, and that is important. Also, how the patient is able to adapt to use the medication in their family routine and their work routine, and also the need to comply every day with treatment. These are elements that make it difficult. And many times when we do the diagnosis, the patients were asymptomatic, and the diagnosis of CML is done through a blood exam, for instance, pathology test, and the treatment makes them feel ill and creates symptoms, and this impacts compliance as well. So when we look at the social aspect, it's always important to see what support network they have, what is their family situation, if they have the possibility to be part of patient groups, and also if socially or culturally regarding these diseases such as cancer, if there is any cultural barriers. Also, at the level of the health system, what is the relationship that the doctor and the patient have? This two-way street. Also, the capacity, the possibility of having a group of people that can support the patients, such as nurses and social workers. What is the healthcare training as well? Because not all teams have the same training. What is the access to treatment that the patient has? Uh, as we just talked about, access to treatment and monitoring as well, and how many times access to medication determines what we can choose or not. And many times this access to monitoring also impacts our decision-making process. And also linked to these chronic diseases, there's also a financial impact and sometimes logistical challenges as well, where the patients that live further and where the reference center is not as accessible. So all of this makes us think that these patients, more than any others, they need to have a multidisciplinary approach that needs to be as holistic as possible, and that we need to be able to integrate these different interventions. We have education interventions, patient empowerment, how we can bring down the barriers in the health system, how we can enhance our communication, and also in our era, how can we incorporate these technological tools in our favor so they can support us in the follow-up of these patients. So we can use social media, cell phones, we can have online medicine as well, and this can also helps to improve adherence. So continuing with this concern that we have in our Uruguayan group, we're working now to develop an app for our patients. And the goal is that it can be an educational tool that is interactive, that patients can ask and request information about the topics that are important to them. Maybe it's not what we think they need. And also, an alarm system and also electronic pill dispenser that will allow them to comply, help them to comply with medication. Also, to report adverse effects that are not as important, but what they have to go through every day. But basically, we need to think together, and what David has to share with us will be very important. Because when resources are limited, what are the strategies that we can develop that will improve adherence of our patients? And in these clinical cases, we focused on young people, but perhaps David can tell us if he uses different strategies for older patients.
Wow, what a wonderful investigation of that topic. That was fantastic. And I have to say also, hats off to the interpreters. It isn't often that we get the full benefit of listening to the interpreters do their job. That was amazing. How good. Thank you. Thank you very much. Okay, well, David, would you like to start, please?
Yeah, thanks. Thanks for that wonderful two cases, Ana Inés. It's a very uh, complex and sometimes intractable problem. I think what you have outlined, I think there are two different cases with slightly different issues. I think the first case, if I can actually just come out right to say it, I think the first patient probably, as you have said, has a personality disorder that makes her sort of steers her to bad decision making. If she didn't have CML, she would probably also do other bad things to herself, as you have rightly mentioned. And I think, having mental health support and treatment there is probably just as important as everything else that we can do to ensure compliance. And I think the issues there are different to somebody who comes to you and say, I understand what you're telling me. I choose not to follow your advice, and that is my decision. So that is patient autonomy. They have a right to do what they do. You have done your job. They have told you that they have understood your advice, but they choose not to proceed anyway. And then there is, as you said, another type where they either have poor health literacy, so they don't actually believe or quite understand the importance of what you're trying to tell them, or they may have preferences for other therapies, such as traditional therapies. I don't know how common that is in Latin America, in some Asian countries where I have collaborators. That is not uncommon, and it may either be used to replace what we have available, or it may be added, in which case it may interfere with what we have available in a drug-drug interaction. I don't actually know how I would treat these two patients differently compared to what you have done. In a clinical, practical sense, I don't actually have any further suggestions. It's not as if I go, I think you would be able to use X or Y or Z. I think sometimes young people grow up. I mean, CML is a long game. As long as they don't do anything too stupid, when they find the right partner, when they have children, I see a 180-degree change in how they comply, because things that they value are different. And sometimes you just hope and pray that they don't transform to blast crisis until then. And your point of using family to support young people is also very important. We see some young people, the initial support network may be mother, siblings, sisters, brothers, that would do the nagging that you would nag, and then the mother says, yeah, right, I have told you that your doctor would say that. And then they grow up a little bit more, and that support network might be a girlfriend or a partner. So I'll tell you a funny joke. So I had a 20-something-year-old man who's non-compliant, and he would come with his girlfriend, and his girlfriend would be on my side and say, "Look, I told you, the doctor says you have to take your drug." And then the girlfriend says to me, "Next time he doesn't take his drug or doesn't do his blood test, I will tell him to do the right thing. You just send all the emails to me, you just call me, and I'll make sure he does the right thing." And then one day I called the girlfriend and I said, "Jess, you know, Damien hasn't had blood tests for a while." And you know what she said? "Look, sorry, we broke up." That's another reason for non-compliance. So, but it's important, to use the allies that you have to try to try. But I mean, sometimes you just do the best you can, don't you? I don't know. Do the others have any helpful hints?
Lillian, what would happen in your clinic?
Well, we don't have big problems of adherence, but it is true that the younger patients are the most complicated, and I explain them the seriousness of their disease, and sometimes they miss the next control anyway. So this form of seeing if the patient comes to their control and calling them is an important step. David mentioned that he called the patient because he didn't have his blood tests done, but I don't know if that's a task done by the nurse or the doctor, the physician in Australia. Because in our country, maybe it would be ideal to have a nurse dedicated to that, but we don't have sufficient professionals.
Yeah.
And
in my center, it's the medicals who do that. I agree with you. Having a nurse to actually have more time to form a relationship with these patients sometimes are very helpful. For some diseases like transplant, we have transplant nurses, but for CML, it's just me. Kendra, he has physician's assistants who do the nagging for her. but no, you and me.
we need a nagger.
Yeah.
I've got a good team of naggers for sure. I agree though. The younger patients are absolutely the more challenging group. There's no question about that. And it's all different reasons. Some, it's just not wanting to really come to terms with the fact that they have a cancer diagnosis. Some are just still believe they're invincible. There are obviously those with personality disorders and other mental health issues that you can't really, we don't have the capability of changing. I had a young guy, he was 16 when he was diagnosed, and he was started on dasatinib and he was doing beautifully. I mean, so well. And his mom is a gastroenterologist, and he was living at home. Obviously, he's in high school. And then we were almost at 3 years. He really wanted to discontinue. We had a plan for him to, he was going to leave for college. He was going to come back. And assuming everything was still fine, we were going to stop his dasatinib and see how he did. And so he left for college. He came back a couple months later, and he had lost MMR. And I was like, what the heck happened here? And I mean, it was that he went to college and his mom wasn't there every day saying, take your dasatinib. And that was, even though she said she sent him a text message every night at the same time. And then she started feeling like she was irritating him. So she would just send him a little heart emoji every night that meant take your dasatinib. And he just didn't. And I don't know. I mean, it's hard. So I think, but there is some data that says that adherence is improved in situations where patients feel like, not that they understand the risks of not taking the drug, but if they just understand the disease. So if we take the time to educate someone on the disease and what it is that we're trying to accomplish, like what is this drug actually doing and what are we trying to do with it, that can help improve compliance. But I think, again, that's in some patients, but not all. Some patients don't, they don't want to hear all that. So It's tough. This is a tough topic, for sure.
Ana Inés, what do you think of?
So the strategies, I think, I mean, we all share the same strategies, quite frankly. And what David was saying about, us not always having that much support and from other professionals, so it's us doctors reaching out to the patient, to their family members, trying to get them engaged, and that job of educating them day in and day out and talking to them and answering questions. And sometimes we think that it's a patient who understands everything perfectly and is perfectly compliant, and we end up running into a surprise because sometimes it's like pulling teeth, right? I mean, I'm going to insist and insist up until they understand. And sometimes it's facts of life that help them become more aware, such as becoming a parent or seeing somebody else becomes fall ill. Sometimes it's hard to acknowledge that we have a chronic disease, that we're not invincible, especially for the young. And sometimes growing up helps. But the thing is that what makes us anxious is that we don't know whether the disease will be indulgent enough and they won't go on to more advanced phases before they actually become more compliant. Then older patients do not have that many compliance problems, and the problems have to do with intolerance or having to do with the fact that they take a lot of medication, and the idea is to avoid interactions that might lead to toxicity or actually that might nullify the effect of those of our medications. And of course, education is a must. And we now have this app. The idea is to send reminders, to be more present, and try to give our patients what they need or they want to know, which sometimes didn't come to mind, and we didn't know about.
Thank you, Ana Inés, and I wonder if we might take the development of your app out to the wider group at some point, because that sounds like it's yeah, in addition to all the other naggers that Kendra has and that we need in our lives to make us do things. That's a great idea, a great innovation. Do we have any last comments or questions from our experts on this topic?
I just wanted to add that in our patients that have social economic problems added, the going to the hospital and taking the exam, then going again and seeing the doctor, and then another trip to uh, get their medicines. It is great if we have a team that can take the exam the same day as the day that he sees the doctor, and then have the test and tell them or be aware that the exams are the results when they are ready. So that alleviates a burden, an economic burden for the patients. That is important to maintain their adherence to therapy and control.
Kendra and David, any last comments?
No, I think what Lillian has said is very important. We can only try to remove any barrier that we can to adherence and make it easy for the patients. And yeah, we can only do our best. Arlene, I think there's somebody with their hand up.
Virginia, yes, Virginia, would you like to come into the discussion?
Yes, yes. Well, an excellent topic and an excellent conversation. I just wanted to add one thing that helps in adherence is the community of patients with leukemia, like patient groups. they help a lot to make people get adherence, because sometimes they understand better the disease by talking to others. And I think that's something that we should never forget, to work with people from the patient societies and patient advocacy groups, because they're very good at that.
Indeed, there might be a couple of representatives from those groups with us today. If they'd like to make a comment, they're also welcome. Otherwise, Ana Inés, could I get you to take your slides down, please? Ana Inés, thank you. And any last comments from anyone on this topic, which has been really fabulous? Okay. In that case, we will say thank you very, very much to our experts for today. Dr. Kendra Sweet, Dr. Lillian Pilot, Associate Professor David Yeung, and Dr. Ana Inés Prado. That really was a fantastic discussion. So good, so good. We'll call it for today, but of course we hope to see you again soon. The next Latin American discussion will take place on Thursday, the 2nd of July, same times as today, and we'll go back to the CML laboratory and ask how to get the best out of it when resources are limited. We have a great team of experts lined up for those discussions. Please join us for it. I did see Dr. Gabby Jaramillo join us earlier. I hope you enjoyed the discussion today too. And we hope to see you online. We have a new website, so please go check it out for ways to keep up with all the CML news via the newsletter. We'll send you papers of the month, keep you up to date with upcoming meetings, webinars, links to summaries of conferences or discussions. And also via the website, you can engage with our interactive case discussion forum, where we take difficult or interesting cases to the key experts in the field for their advice or commentary. If you aren't already familiar with the ICML Knowledge Center, also please go check that out. There is literally a wealth of knowledge in there with many dedicated modules and a major new module, Next Steps in CML Management, currently in development with initial releases scheduled for July. It'll be great. Or you might like to join our social media outlets, Facebook, Instagram, X, formerly known as Twitter, or whichever you choose to engage with. And that's it from me. Thank you very much. Gracias y obrigado. And I hope to see you all again on the 2nd of July. Thank you.